Hello, everybody. Welcome back to Step 1 Prep. Today we are on question 131. These are all original questions. They are not copied from or taken from the MBMEs. However, it's everything that I believe you should know at this point in your prep by the time you've finished, all the way through MBME 29. Let's not waste any time. Let's dive right in. 17-year-old girl is brought to the emergency department with high fever, photophobia, and petechial rash. She has a history of 2 prior hospitalizations for Neisseria. That should immediately make us think of deficiency in the MAC complex formation. And indeed, our correct answer is the deficiency of the terminal complement components. All right, so this is a very easy question. I want to break it down simply. The terminal complement pathway, which is C5 to C9, forms what's called the membrane attack complex. And the MAC creates pores in the membrane of gram-negative bacteria. And so a deficiency in these complements, especially C6, 7, 8, or 9, causes an inefficient MAC formation. And that allows for these gram-negative bacterium, for instance, Neisseria infections, think Neisseria meningitis or Neisseria gonorrhea, to be able to form. And other infections are not as common because opsonization, which occurs via the C3b pathway, is usually intact. So this is a really basic immunology question. It's about the complement system. You should look for a deficiency in C5 to C9 if you have recurrent Neisseria bacteremia. All right, there's our explanation. Let's look at the trap answers and why they're wrong. C1 esterase inhibitor. So that deficiency causes what's known as hereditary angioedema, not infections. And the pathophys there is you have increased bradykinin because of the unchecked kallikreins, which are the family of the serine proteases that are involved in all sorts of things like blood pressure regulation, inflammation, tissue remodeling, all that stuff. So with C1 esterase inhibitors, you should think of the condition known as bradykinin-mediated angioedema because that's life-threatening swelling of the deep layers of the skin or the mucosal tissues. And this is actually different than histamine-mediated angioedema, which often includes like hives and itching. This type is non-pitting and it's not accomplished by urticaria. I don't want to get too deep into the weeds here, but this pathophys involves the contact system, which is a plasma protein cascade that's responsible for inflammation, and that causes an excessive accumulation of bradykinin. And bradykinin is a vasodilator that increases the vascular permeability and leads to fluid leaking from the blood vessels into the surrounding tissues. And so C1 esterase inhibitor, that's a key enzyme that normally inhibits that contact system. And so if it's deficient or dysfunctional, hereditary angioedema or something else, that will cause uncontrolled activation of the pathway. And then you have unchecked kallikrein activity, and plasma kallikrein will not be properly inhibited, and that's what causes the excessive bradykinin. Also be on the lookout for angiotensin-converting enzyme ACE. That's a metabolizer of bradykinin, and so if you give somebody an ACE inhibitor, that will block that process, and it leads to bradykinin buildup, and that can be a life-threatening angioedema. All right, so we dove way into that option. IgA deficiency would have recurrent mucosal infections. Does not explain the Neisseria, so think mucus for that one. Factor H deficiency, atypical hemolytic uremic syndrome, that regulates the alternative pathway, which is not selective for Neisseria. And beta-2 microglobulin deficiency would be an absent MHC class 1. And so that's associated with CD8 positive T cell, which remember MHC 1 times 8 equals 8, whereas MHC class 2 times 4 would equal 8. So this is not Neisseria. But individuals who do not have the C5 to C9 complexes are at about 7,000-fold increased risk of getting Neisseria infections. Okay, so there are the buzzwords and the associations. One thing I want to note is that factor B and H should make you think of the alternative complement pathway. Factor B makes C3 convertase, and factor H regulates that convertase. And so if those are deficient, you have uncontrolled complement, and that's atypical HUS, not Neisseria infections. And then the other thing to know is that these beta-2 microglobulins are components of the MHC class 1 molecules, and so deficiency impairs CD8 positive T cell activation. The long story made short here, that recurrent Neisseria infection should make you think of MAC C5 to C9. All right, for our next topic, I like this title, Don't Drink and Dose. So let's dive in. We have a 21-year-old college student presenting with follow-up after beginning treatment for chlamydial urethritis with oral doxycycline. He reports that despite strict adherence to his dosing schedule, his symptoms have not improved over the last 5 days. Further questioning reveals that he takes his medication every morning with a bunch of milk products. Which of the following is likely the explanation for the reduced efficacy? The answer is complexation with dietary calcium. So we have a patient coming in with acne treatment using tetracycline, but it stops working when he has milk, essentially. So to answer this question, we have to know what tetracyclines are, like tetracycline, doxycycline, monocycline. These are bacteriostatic antibiotics that inhibit protein synthesis by binding to the 30S ribosomal subunit. And they are highly sensitive to a process known as chelation. And that's when the bi or polydentate ligand bonds with a metal or a metal ion and it forms a stable ring structure known as a chelate ring. Usually chelation is a treatment for people who have too much metal in their body. It removes the metals and other elements, right? Because the chelator is attached to the metals in your body, and your body can then get rid of those metals through the urine and the feces. And as we were saying, are super susceptible and sensitive to chelation. So divalent cations like calcium, iron, magnesium, they bind to tetracyclines in the GI tract. And this forms insoluble complexes that cannot be absorbed, and so you have decreased bioavailability. And the thing that you should know then, okay, why are we talking about all of these awesome divalent cations? Well, milk contains calcium. Check the charge. Divalent. So that chelates tetracycline and it prevents its reabsorption. So this is an antimicrobial tetracycline question in the pharmacology realm. You do not take milk, that is to say calcium, a divalent ion, or antacids. Why? Because that's also going to have magnesium, which is also divalent, or any iron-containing preparations because divalent cations can inhibit the drug's absorption in the gut. A, enhance metabolism by hepatic enzymes. Nope, doesn't use the CYP heavily. C, competition with other ones. That'd be like warfarin displacement. It has nothing to do with the protein binding competition with warfarin. Degradation in acidic environment, that's acid labile drugs, and altered renal excretion. Doxycycline is mostly fecally excreted. So yeah, drinking milk can actually make your antibiotics stop working. Also be on the lookout for things like iron supplements. In another world, they could have asked this question differently. Calcium supplements, antacids, magnesium is divalent, even, zinc. Just be aware of the effect that chelators can have on tetracyclines and anything that binds the 30S subunit. In our next question, we have a 56-year-old woman presenting with worsening fatigue and decreased urine output over the past 2 weeks. She also notes spotting of blood after intercourse and pelvic discomfort. Her past medical history includes chronic tobacco use and no recurrent gynecologic exams. Lab results show elevated serum creatinine and BUN. Pelvic ultrasound shows bilateral hydroureters and hydronephrosis. No stones or masses are noted in the kidneys and ureters. Pelvic examination reveals ulcerated cervical lesion. Which of the following is most likely the cause of her renal findings? Before diving into the answer, I want to explain the lay of the land. Cervical cancer, when it's locally invasive, can spread laterally and involve the perimetrium and the ureters, especially near the ureterovesicular junction. And that is what's causing in this patient the bilateral ureteral obstruction, and that leads to the hydroureters, hydronephrosis, and postrenal azotemia. And what is postrenal azotemia? That's when you have an increased BUN to creatinine ratio. So this is a reproductive female gynecological tumor question. You just have to know the only common cancer that causes bilateral ureteral obstruction due to a local invasion. It's invasive squamous cell carcinoma of the cervix. It can invade locally and invade the ureters. And that can then cause the renal failure. And the most common site of the distant metastasis in cervical cancer is actually going to be the lungs. Now, I just wanted to clarify postrenal azotemia and how it relates to BUN and creatinine. So azotemia is just a fancy word of saying, hey, we've got elevated androgynous waste products, primarily BUN. And there are 3 categories that you should know. There's pre-renal, intrinsic, and postrenal. Intrinsic is where you actually have damage to the kidney itself. There you should think of acute tubular necrosis. Postrenal is an obstruction of urinary outflow. Stones, in this case, cervical cancer. And so in postrenal azotemia, what happens is you have an obstruction. The urine backs up to the Bowman's space. If you have increased hydrostatic pressure, that reduces. Well, GFR depends on the Starling forces across the glomerular capillary membrane. There's a blockage downstream, right? Like cervical cancer compressing against the ureters. The urine then backs up to the renal pelvis, and then in the collecting ducts and the tubules, and ultimately all the way into Bowman's space. Bowman's like, yo, because of this blockage, you're in my space. Now, why does this lower GFR? Well, that increased pressure in the Bowman's space pushes against the filtration of the plasma from the capillary. And so even if glomerular pressures are high, the net filtration pressure will drop as the GFR decreases. Maybe a good analogy for this is imagine you're trying to pour water through a hose into a bottle, but then the bottle is like full and it's like sealed. That water has nowhere to go. And so pressure is going to build up and stop more water from flowing. So just to make sure that we're getting this topic right, and again, I don't want to go too much into the weeds, but this is super important. You should know what pressure increases in postrenal acute kidney injury, and that is hydrostatic pressure. And where does it occur? In Bowman's space. And then what's the immediate effect? It decreases the GFR. That's what's important. Okay, I felt like I had to explain that briefly. And you should know there are all sorts of BUN creatinine ratios. For pre-renal, you've got like 20-1 BUN to creatinine. For intrinsic, it's less than 15. It's at 15-1, but then later it's less, 15-1. So in early post-renal, the BUN is increased because urea reabsorption continues and creatinine stays low in the serum. But don't get too bogged down on that. This is just outflow obstruction, stones, BPH neoplasms, that's what we're looking at. Maybe even congenital abnormalities that stop that flow. It's post-renal. So obstruction, you have elevated BUN to creatinine ratio. Cool beans? I think those are some cool beans. All right, here are some of the answer choices. Clear cell would be a renal mass. High-grade serous carcinoma of the ovary might compress them if large, but it's less common. Bilateral, unless it's super big. And adenocarcinoma of the colon, you'd have change in the bowel habits, and obstruction would need to be extensive and posterior. So cervical cancer can cause kidney failure because it doesn't necessarily stay locally. It invades the tissues next to the cervix and it compresses the ureters. So yep, that's cervical cancer. All right, here we have a 62-year-old man. It could also be a female. Middle-aged, it could be a lot of things. I'm going to go ahead and pop up right here a 62-year-old man. So he's got a history of rheumatic heart disease presenting with sudden onset diffuse abdominal pain for the last 3 hours. He describes the pain as 10 out of 10 constant. On exam, he's AFib, diaphoretic, and has a irregular pulse. What's the mechanism behind his condition? The answer is a mural thrombus formation and embolization. So it's acute mesenteric ischemia due to embolism of the left atrial thrombus. He's got mitral stenosis, and it predisposes him to thrombus formation. So the SMA is the most common abdominal vessel that gets blocked in a cardiac embolus. And that's because you recognize the irregular results here, which is AFib. So the atria stops contracting effectively, and so the blood starts to pool. Then that causes a thrombus. So you can see this in several different ways. They could have asked about, a male, they have abdominal pain, irregular pulse. That's always going to be the case. And every single time you see that, it's AFib. They might say there's an opening snap or there's some diastolic murmur. That's mitral stenosis, right? And on imaging, you could see maybe the small bowel and colon distension. Basically, what's happened is there's acute mesenteric ischemia. There's embolization, which is the procedure where, block or close off a blood vessel using a substance called an embolizing agent. And it's used to treat different conditions like abnormal blood vessels, internal bleeding, tumors, all that stuff. But the cause could be the embolization of the atrial thrombus due to AFib. So AFib causes the stasis of the blood in the left atrium, especially when it's enlarged, such as in mitral stenosis. And so that leads to thrombus formation, embolization to systemic circulation, and the superior mesenteric artery is super susceptible. Why? Because it's got high flow. A lot of blood going through there, and it's also got a narrow angle. And so you can have a sudden occlusion of the SMA that causes ischemia, and that's why the small intestine is having problems, and the transverse colon are having problems. It's sudden abdominal pain that is out of proportion to the exam. This is severe. In the question stem, we had severe pain, so it's not it. Hypotension-induced watershed infarction. That affects the splenic flexure and the rectosigmoidal junction. That's seen in shock states affecting the low flow areas, not the SMA. They could also ask about hemorrhaging. Well, that would lead to hypoperfusion and non-occlusive ischemia. So that's in the watershed areas like B. Spasm of splenic arteries. That'd be in cocaine use, intense vasoconstriction, and local thrombosis due to endothelial erosion. You don't have atherosclerosis history, so embolism is primary here. It's not some sort of a plaque rupture, right? That'd be atherosclerosis, like a coronary artery disease or something like that. And that can trigger a local thrombus, but it's a lot less likely in the embolism in somebody who has AFib and no atherosclerotic risk factors. And a thrombosis is very possible, but you'd have to look out for something like a hypercoagulable state, antiphospholipid syndrome, or cancer. So it's less likely in the embolism. If somebody's got AFib, that's usually going to be the cause of the embolism. So the most common artery that's affected by embolic acute mesenteric ischemia is definitely the SMA. And the classic EKG finding is irregular rhythm, and that's AFib, and the valvular disease that predisposes you to AFib, and also left atrial enlargement, which is the cause of this patient's condition, is mitral stenosis. All right, in our next question, we have a 60-year-old woman with a 10-year history of poorly controlled type 2 diabetes. This could also be a man as well, so I've got my demographic photo representing that. Discomfort in the lower legs for the past 3 months. She says the pain is worse at night and describes it as tingling fire ants crawling up from my feet. She finds some relief warming her feet. On exam, she has decreased vibratory sensation and pinpricking of below the knees, diminished ankle reflex, and intact motor strength. Which of the following describes the nature of her pain? The answer is burning pain. And what we have to do is recognize that male or female, what this patient is experiencing is called, it's diabetic peripheral neuropathy. The most common type is symmetric distal sensory motor polyneuropathy, and it's burning because neuropathic pain is described as burning or tingling, electric shocks, pins and needles. That's what people feel. It's worse at night. And that's because it's unmasked whenever it's not, the patient's not distracted. It's improved by warmth, like a hot bath, and vasodilation can actually improve that microcirculation. So what we have here is an endocrine question, diabetes, diabetic complications. We have a symmetric distal sensory motor polyneuropathy, glove and stocking distribution with burning and tingling pain. Stabbing is for radiculopathy or localized nerve impingement. Cramping for muscle fatigue, aching, musculoskeletal or inflammatory pain, and tightness. Could be spasticity or claudication. And what's crazy is 50% of diabetic patients develop peripheral neuropathy sometime in their life. So it starts with just some numbness, maybe some tingling in the toes. Then you have a lot of burning pain that people recognize in the nighttime. It's not colicky pain that's seen in visceral pain, like the renal colic or bowel obstruction. And it's like often sharp. And the cramping itself is often due to muscle ischemia or an electrolyte imbalance. A sharp pain is somatic pain and trauma, not burning or electrical pain. And so they might also ask you what type of nerve fibers are affected first in diabetic neuropathy. And the answer there is the small fibers. Pain and temperature, that explains the burning pain. And those guys are the vibration fibers, the proprioception fibers. And so the treatment for this is you give them TCAs, which is kind of confusing at first, but amitriptyline is what you give these patients. SNRIs like duloxetine and gabapentin or pregabalin, but you have to avoid long-term treatments of like opioids. Those are not first line for neuropathic pain. Neuropathic, you give them a TCA, SNRI, or gabapentin. All right, so diabetic, small fibers to large fibers, burning pain, TCAs, SNRIs, gabapentin. That's the lay of the land. That's what you need to know. All right, next, a 48-year-old man with a 25-pack-year history of smoking presents to his primary care physician with motivation to quit smoking. It could be male, female, obviously, so my demographic just chosen a female. He's tried nicotine patches and bupropion without success. He is prescribed a medication that mildly stimulates nicotinic receptors while simultaneously reducing the reward effects of nicotine. What's the pharmacologic classification of this agent? It is a partial agonist at the nicotinic acetylcholine receptor. So we have a heavy smoker, right? They could have tons of packs a day for a long time, and they've tried quitting and they need pharmacologic help. And so the doctor will choose a drug that has to do two things. One, has to reduce cravings, and it also has to block the CNS stimulation from nicotine. So we needed a drug that acts at the nicotinic receptor but is not fully activated. And so we need a partial agonist. So they've given them Chantix, also known as varenicline. It's the partial agonist at that nicotinic acetylcholine receptor. In the CNS, it stimulates the receptor just enough to reduce these cravings, but it also blocks the full activation of nicotine, so it blunts that reward pathway. And so the dual action helps people prevent and reduce their withdrawal syndromes, but also prevents the relapse because it makes smoking less rewarding. So pharmacologically, you have the psych drugs that cause the smoke cessation here, and it's cycline is a partial agonist at the nicotinic receptors. Now, it's not a complete agonist, right? Full agonists like nicotine itself would just activate the receptor fully. And so you need replacement therapy like patches or gum to do that. But it would not block the CNS stimulation. It would just mimic smoking. Antagonists would block nicotine from binding, but it does not reduce the cravings. Bupropion is close. It's an atypical antidepressant. And it's also a nicotinic antagonist and dopamine norepinephrine reuptake inhibitor, but it's not as effective at reducing those cravings directly. And it's not an inverse agonist because that's rare in a clinical pharm. And that would do the opposite of the receptor activation. So that would even worsen the withdrawal. So you definitely would not use that there. And so we have to know for this question, what is varenicline's mechanism of action? And for that, we have to know it's a partial agonist at the alpha-4 beta-2 nicotinic acetylcholine receptor. And what are the major side effects of it? Nausea, vivid dreams, neuropsychiatric symptoms like depression, suicidal ideation. But we should also know some pharmacologic options for smoking cessation. So we talked about varenicline, that's partial agonist. We also have talked about bupropion, that's norepinephrine and dopamine reuptake inhibitor, and also a nicotinic antagonist. And then there's nicotine replacement therapy, just the gum and the patches. That is a full agonist. And so the question is, why do we care about nicotinic receptors in smoking cessation? Well, nicotine and nicotinic receptors, what's the connection there? Because nicotine binds and stimulates the nicotinic acetylcholine receptors in the central nervous system, right? That's how nicotine works. And so nicotine is an exogenous agonist at the CNS nicotinic receptor. And so you have a dopamine release because of that, and that causes the addiction. It's the dopamine release, the nicotine, exogenous influence, nicotinic receptors, nicotine, nicotinic, dopamine. That's the whole shtick. And so nicotine crosses that BBB, the blood-brain barrier, and it binds to the alpha-4 beta-2 subtype of the acetylcholine receptor in the ventral tegmental area, the VTA, and that leads to the dopamine release into the nucleus accumbens, and then you have reward. You're like, oh my gosh, I really love that sensation. And so varenicline helps because it's a partial agonist at the alpha-4 beta-2 receptor of the nicotinic acetylcholine receptor, and it stimulates just enough to reduce those cravings. It's a partial dopamine release. It's like, okay, I kind of like that, but it also blocks the nicotine from binding, right? So it blunts the full reward. And so you get less withdrawal, less reinforcement if you relapse, and it's easier to quit. So varenicline, partial agonist at the nicotinic acetylcholine receptor. Cool beans? Got to reduce those cravings. Got to block that nicotinic reward. All right, our next question, we have a 42-year-old man presenting with 10 days of severe right-sided headaches. The last 20 to 40 minutes, he says the pain is excruciating. centered behind his eye, occurs daily at 2 a.m., waking him from sleep. So this is recurrent, unilateral, short duration, severe headache with autonomic features like trigger pattern with alcohol and also like a nocturnal timing. So all these things are pointing us to a cluster headache. And that is indeed our answer. So we have recurrent, short duration, severe headaches. Oftentimes what they'll do is they'll pick a side. Usually they'll say like, oh, we got the left side. It's like 30, 60 minutes. It occurs daily. Usually at night, there's some tearing and redness of the eye and it's ipsilateral. There's nasal congestion that's also, and then when we drink alcohol, it causes more pain to occur. So basically what you should look out for a cluster headache is unilateral and severe, and it's behind the eye or the temple. And it's associated with autonomic symptoms on the same side. So think lacrimation, conjunctival injection, nasal congestion, rhinorrhea, and sometimes ptosis or meiosis, like partial Horner syndrome. And it occurs in clusters. You should also know that 100% oxygen is abortive and verapamil is prophylactic. So migraine with autonomic features, these are longer, 4 to 72 hours, and not male predominant. Paroxysmal hemicrania, response to endomethacin. That's going to be rare in men, and also you're really not going to see that tested on step 1. Many more frequent attacks would be seen there. Trigeminal neuralgia would have electric shock pain that's triggered whenever you touch something. Temporal arteritis is jaw claudication, and the ESR would be elevated, and here you have vision changes as well. So alcohol is the trigger, but it's not. The pathogenesis involves the hypothalamic activation, not just vasodilation. Allergic rhinitis can mimic some of the symptoms like lacrimation and congestion, but it's usually mild, not painful. It's not just basic allergies, right? There's no like severe headache there. It's not triggered by alcohol, would not be non-episodic. And it's not like a CNS neoplasia, because there you'd have the brain tumors that are progressive and constant dull headache, and it's often worse in the morning or with a Valsalva maneuver. And it would not cause a reproducible, short, sharp daily attack, especially wouldn't have ipsilateral autonomic symptoms. And that giant cell arthritis we talked about, another big factor there is it occurs in patients that are greater than 50 years old. Headache is often diffuse and it's localized to the temples, and it's seen with jaw claudication, vision loss, and elevated ESR levels. This patient is actually pretty young, relatively speaking, and so it's not going to be a jaw claudication issue with temporal arteritis, giant cell arteritis. So yeah, the first line abortive treatment for the cluster headache is 100% oxygen. Give them a non-rebreather mask. And first line prophylactic is verapamil. And what helps you distinguish this from other headaches, you have the male is greater than female, nocturnal onset, seasonal pattern, and the pain is like super, super severe. That's cluster headache. All right, here we have a 2-year-old boy. It could be a girl as well. So I've given the demographic picture of a girl. Looks like she's tugging on her ear. She's got some fussiness, runny nose and cough, pulls her ear and she cries. Which of the following describes the anatomical route? The answer is pharynx to the auditory tube to the middle ear. This is acute otitis media because it travels in the nasopharynx to the middle ear via the auditory tube in young children. Inflammation traps and you get the infection. So oftentimes they have a history of chronic otitis media and they have a sore throat, mild cough, ear pain, irritability. They pull on their ear, that kind of stuff. There's usually some fluid behind the tympanic membrane. And all of that leads you to think of acute otitis media. And so you have to know the way that spreads. So the eustachian tube is another word for the auditory tube. And that's why students will miss this particular topic, because they don't realize the eustachian tube is the auditory tube. And it connects the nasopharynx to the middle ear. And so in children, you have a really tiny, short, and wide tube, and it's more horizontal than in adults. And that makes it easier for upper respiratory infection pathogens to ascend from the nasopharynx into the middle ear. And so you have the results of fluid accumulation and inflammation, which is, going to lead to otitis media. So this is just like head, ear, nose, and throat question, otitis media, infection of the middle ear. The pathogens ascend from the nasopharynx via the eustachian tube to the middle ear. It's not the laryngopharynx. The eustachian tube connects to the middle ear, not the inner ear. Oropharynx, there's no communication like that. Nasal is unrelated to the cochlea. Tracheal is part of the lower respiratory tract. There's no direct connection to the eustachian tube. And mastoid to middle is adjacent to the middle, but the secondary sites of infection. And this is actually super common. 80% of children are going to experience at least one episode of otitis media in their life by the age of 3. It's that horizontal construction in the young little kids, the shorter ear, the wider ear, the horizontal ear, all that stuff. Acute otitis media goes through the eustachian tube to the middle ear. All right, if anybody asks, just say that my numbers are modern art, because that is a wonky looking 3. In this question, we have 800 adults after 3 months, 180 in the intervention, and 40 skipped multiple sessions. We want to see the primary outcome based on the original group. This is intention to treat, so you analyze all based on the initial group allocation. This is super simple. It's just intention to treat analysis. All participants are analyzed in groups that they were in originally. That's all there is to this. It's super simple. Intention to treat. Moving on to the next one. All right, step 1 loves to ask about anastomosis. We have a 68-year-old man with a history of hypertension and smoking undergoing elective open surgical repair of the infrarenal abdominal aortic aneurysm Intraoperatively, the left testicular artery is ligated to allow vascular access. Postoperatively, he has no signs of testicular ischemia. Which artery is most likely maintaining perfusion to the left testes? All right, so the key to this question is knowing where the testicular artery originates and who backs it up when it's lost. The answer is the artery to the ductus deferens, if the testicular artery is damaged or ligated. So this is just an anastomosis question. So here's the explanation. Superior vesicular artery supplies the dome. Internal pudental gives rise to the scrotal branches, but not anastomosis with the testes. Middle rectal artery supplies the rectum. Superficial epigastric is a branch of the femoral artery, supplies the lower abdomen. All right, so this is just an anastomosis question. And on the step exam, you can see a lot of these anastomosis questions. Like there's the SMA to the IMA. If you have a AAA repair, then the IMA is sacrificed, so you need the SMA collaterals. Here's a practice question about that. Basically, a guy undergoes a procedure. What do you do? Middle colic via the arc of Riolin, that's the collateral pathway for the middle colic artery. So just know that the SMA touched the IMA. And there are all sorts of anastomoses to know, like GI tract, SMA, IMA, celiac with SMA, portal with systemic. You have esophagus, the esophageal varices, rectum, the anorectal varices, and the umbilicus, the caput medusa. That's the paraumbilical with the epigastrics. Rectum has the superior rectal with the middle inferior, and left gastric with the azygos. The pelvic reproductive, you have testicular ovarian artery with the artery of the ductus deferens or the uterine artery. So uterine, ovarian, artery of the ductus deferens, testicular. Know those two things together. Uterine artery, ovarian artery. In a hysterectomy, ligation of uterine artery must spare the ureter. And ovarian artery preserves the perfusion to the ovary. In the thoracic wall, you have internal thoracics and intercostals, bronchial and pulmonary arteries. In the lower limb, you have inferior epigastric and superior. The deep circumflex with the iliolumbar supplies the iliac crest. The brain has the circle of Willis, anterior and posterior communicating arteries. And so here's a big old list. These are all the anastomoses that you probably need to know on test day. Celiac SMA, ovarian uterine, portal systemic, SMA IMA, bronchial pulmonary, IMA external iliac, thoracic, intercostals. If you guys found this helpful, then please consider liking and subscribing, and we'll see you guys in the next video.